I'll spend next around 45 minutes with you to give you a glimpse of what is important in a sperm and how we are evolving from, say, 1970s to 2021 in semen analysis all over the world. Just all about evolution, so that you know how much work the people have done to bring you till here. These are two telephone numbers. You can take down our telephone numbers. You can just copy in case you have time. These are numbers you can copy in case you want to contact us anytime in future. And we'll also put them in the chat box before we end. And you feel free to send up an WhatsApp message. A large number of you have joined today. I believe more than 70 people are from who are not part of our alumnus who are here. So you can take this number. So we want to talk about semen analysis. So how to analyze this sperm. So total number, I'm starting with 254 of you now. Thank you so much for joining in such large number. It's always a great honor to meet you on a Sunday. The problem starts when the sperm count is low, or the count is normal, but there is some other abnormality. That's the time we think about doing semen analysis. And the problem which I normally face is that in our country, around 95% of the gynecologists are females. And as I just spoke to Pooja, she's also spending half her time in the OT doing hysterectomies and cesareans. All of us are basically gynecologists. So keeping that in mind, suddenly we are telling women to become an andrologist. That's a very tricky part, because our OPD, 60% of our OPD nowadays is having some sort of subfertility. And to manage, we have to know about the semen analysis. And then we tell the lady that find time and start learning about physical examination, analysis, hormonal evaluation of the man, which is quite unfair, I feel. But I think so. The call is to be taken by us, how we take it. For telling a gynecologist to know about these glands and secretions is pretty tricky. But that's a way ahead. And I'll try to shorten your learning curve. I'll make an attempt to shorten the learning curve. You have to know that there can be low sperm count, there can be no sperm count. There are different ways to manage a low sperm count and different methods of handling no sperm count. First of all, we have to diagnose them. So diagnosis between obstructive, non-obstructive, azoospermia, oligospermia, normo, crypto is not part of my arsenal today. But these terms you have to know. What are these things and how do we look at them when we do a semen analysis? So that's how a good semen sample should look like. It should be bright, opalescent semen sample. And when we look at the semen sample, we always talk about liquefaction, viscosity, appearance, volume, pH, and blah, blah. We have a lot of these terms which we fill. Sometimes we don't even read them because we are normally treating the man as a bottle. But problem comes when there is actually a problem. When there is a delayed liquefaction or no liquefaction, hyperviscosity, there is a low volume semen sample, low pH, absence of fructose, or complete, all sperms are immotile, they're not moving, which we call as all dead sperms. That's the time when we start thinking about what to do now. So sperms, they lose their agility, they become heavier, they have DNA damage. So that's the time when from the small bottle which we normally use, we start moving towards the deeper analysis. And what all deeper analysis we do from the semen sample is a take-home message I want to give to you. So we have a microscope. Microscope has got some optics, which we teach in the classes for long times. So there are phase contrast optics are there, which we use. And basically, when we have a problem, we try to apply these all things in the semen sample. So we start with the pH, volume, concentration, number. Then we go to motility, morpho. So these multiple things are there in the semen sample, which come into when they're not having a child, when we start thinking about them. Then we start doing CASA, activation. Nowadays we are going into cat spur. Does anyone know what is a cat spur? Any one of you? Has anyone heard about cat spur? So in case somebody knows, you can raise your hand and talk. And that's a chocolate round. Every curtain laser, we have a cake round. Anyone who answers, cake is sent to them in 8-10 days. If someone can tell me quickly what's a cat spur, they'll get a cake. You'll only get 30-40 seconds for that. You can't go to the internet and check. Okay.
It's a calcium channel, sir.
Who said that?
Dr. Hardy from AIMS Nagpur.
Okay. How does it work, Dr. Hadi?
Sir?
How does the channel work, and what is the importance of that channel?
Importance of the channel.
You answer 30 seconds late. KK
I'm
sent
not
for
sure.
immediate answer.
In
So
the
I'm
how?
not
membrane?
sure about that, sir, but it's a calcium channel.
You're right. You're
In
right.
the membrane of the flagella?
No, it's in the mid piece, sir.
But you won the cake. So it's a Catspur channel is the new thing. The future would be in the Catspur channel. Everything depends upon the Catspur channel. So please, you contact me later. Today I'm alone in the group, so contact me later and send me your address. Fine? Good. And Dr. Sangeeta, thank you very much.
Thank you, sir.
Great. Acha laga. So every curtain is there, we have one question which comes to mind. It's an unplanned question. Anyone who answers in 30 seconds get a cake. It'll be sent to you by Amazon.com. So there are multiple causes: pre-testicular, testicular, post-testicular, sperm factors, and which I told you I'm not going to cover about these things today at all. I'm going to a different level today with all of you. So okay, so then we have some causes which are in the hypothalamo-pituitary axis. The problems can be there when there is low testosterone, low LH, low FSH. So there are multiple conditions which we face face normally. There can be some obstructions occurring at various points of time. Yes, okay. There can be dysfunction, alteration, DNA damages. So multiple things are coming to us. And finally, that's a condition of a man nowadays, half the time, because we don't know what we are dealing with. We don't have any answer. So for the man, we don't have much, and we have to depend upon semen analysis for the man. This is what we can offer him. So for the woman, we got multiple options. We can give her antioxidants, we can give her growth hormones, we can give them ovaries, whatever we can give. But for the men, it's only the bottle, and a correct diagnosis can help. So when we get a bottle from the man for analysis, and this has never changed actually. It's something like heart sounds, lub dub, S1, S2. That will never change. So these basic things will never change. The values may change. So we have a liquefaction, volume, color, pH, odor, viscosity, motility, viability or vitality, morphology, count, fructose, and lots of things. And they're not changing, gentlemen, ladies. These things have not changed from the past 30 years. These things are not changing at all. These we have to keep in mind. Only the volume, their numbers may be changing, and how to read the numbers and how the numbers are changing for betterment is what I'm going to talk to you today. So for all these things, you can read WHO volumes, and as our promise, within half an hour, 45 minutes of the class getting over, you'll be getting previous 2 or 3 WHO manuals, and you can read from them. They'll come in the group. So that's great. So there are a few terms which you have to know. Something some people want to know what is aspermia, what is astenospermia, what is endospermia, spermia. The best book to read, this is from WHO Manual 5th edition. So this booklet will be giving to you in next half an hour, 45 minutes. I read from that. But these terms are important. So now when we get the semen sample, we are trying to look at the semen sample in the following ways. We do the microscopic examination, look at number of sperms, motility, morphology, vitality means how many of them are alive. Large number of times the sperms may be there, but we don't know whether they are alive or dead because they are not moving. So to know the vitality of the semen sample, we can carry out things like sperm vitality when they're not moving, look at WBCs, then we look for viscosity, look for liquefaction, look for volume and pH. I told you 30 years, they have not changed. The values go up and down. So this is what we have to learn. And this all what I'm telling you, as I'm building up the topic, these all things are from WHO Manual 5th edition. So I'm going to compare 5th and 6th today. This one 5th edition, it had a fixed volume of 1.5 ml, count of 15 million. motility 40%, morphology 4%, vitality 58%. This is what the fifth edition told us. That came in 2010. Then we have terms, then we have various other terms like volume, liquefaction, viscosity, and we also carry out the pH whenever required, but not in all number of cases. Semen volume is very important. They can be aspermia, hypospermia, hyperspermia. So these terms you should be knowing. What is a normal sample? What is a sample with hyperspermia? When a volume goes more than 5 ml, we call it hyperspermia. Volume less than 1.5 ml, we call it hypospermia. This is all as per WHO 2010. And very gradually, I'm going to take you to 2020, 2021, and then we'll gradually shift over by 1 hour to newer values. That's the plan I want to take you through. So semen may come in different volumes. And one day I got these 4 or 5 bottles. They're not. It's not a planned activity I've done. This is a picture, I think around 15 years old picture when I was, it must be around 2005 or 6. One day I got these many samples for IVF and they all had different volumes. So I laid them here and took a picture. So normal volume is around 1.5 ml plus. Sometimes the volume may be low. We always talk about oligospermia, low count, astheno. Astheno means poor motility. When the sperms are not moving, that is called poor motility. Teratoma means that when their shape has become abnormal, that is abnormal shape of the sperm. So then we divide oligospermia into mild, severe, cryptospermia. Then we have got azoospermia. Spermia means that when there are no sperms after centrifugation of the sample. Crypto means no sperms on viewing under a microscope, but when we centrifuge, we get few sperms. That's called cryptospermia. Then we have got mild, moderate, severe, normospermia. There are some values given, and we should be knowing about these values. These booklets and the database I'll be sending to you on the WhatsApp group, so that will be sent to you by Ashna. Then you can copy from the booklet. So the sperm motility, the progressive motility is the one where sperms are able to move very quickly. That's called PR. Then we have got non-motile, means that they are moving very slowly or only moving their tails. And immotile means that they're not moving at all. They are just silent, but they may be alive. They're not dead. So keeping that in view, we have got a PR value of 32%. Total sperm motility is taken as 40%. So motility is very important. It may be progressive, non-progressive, immotile. And then we have type A motility. We have type A, type B, type C. Type A is more than 25 micrometers per second. Type B is less than that. So this is a criteria which I'll be teaching you today. So this is type A motility or progressive motility. Then we have type B. Type B can be non-progressive. Type C, type D. These are the various types of motilities which WHO keeps changing. So in the 5th edition, they were on PR and P, and now they have come to type A, type B. And in the 4th edition, they were again a type A and type B. So WHO keeps changing. So now another important thing is now we are moving ahead. We're not gonna get stuck at the speed of the sperms. We're looking at the morphology of these sperms. We're looking at the neck of the sperm. We look at the mitochondria. We assess the mitochondria of the sperm. We assess the plasma membrane of the sperm. We assess the nucleus of the sperm. We assess acrosome. So every part of the sperm we are assessing. And when we assess these things, when we look at the plasma membrane integrity, they're called vitality testing. They're called vitality testing. So these are tests. They're called sperm function tests, SFTs, which we do routinely. SFTs can be meant for various various sperm membranes and the parts of sperm. We just spoke about 𝙀𝙤𝙪𝙧, cation. They are the sperm, the cation. They are the ionic pathways in the sperm, which will help us sperm to have these vital functions in them. So nowadays, when you look at hypermotility, acrosome reaction, capacitation, initially we were looking at them separately, but now we are looking at 𝙀𝙤𝙪 proteins. So I'll come to this in some time. So I'm trying to tell you that we are moving away from the sperm number and we are moving to more advanced testing for the sperm. DNA fragmentation has become a vogue. Everyone is doing a DNA fragmentation nowadays. Then you remember in olden days, we had something called liquefaction. We had something called after liquefaction ke baad, we were always looking for agglutination and aggregation. Can someone tell me the difference between agglutination and aggregation? Anyone? Any one of us?
Sir,
Aggregation.
aggregation is when the sperms they attach to the debris and they become
to other
tight.
cells or debris.
And
Yes.
so agglutination is because of the antigen present in the semen.
Yeah. When many sperms are attached together, then it is called aggregation. And when agglutination is when sperms
Agglutination is because of the sperm antigens.
Agglutination.
Motile sperms attached to each other, it is called agglutination. Immotile sperms attached to each other or to any other cells are called aggregation.
Great. You're right. Who gave me that answer? Correct answer?
Sir, Krishna Vignesh from Chennai.
Lovely, Krishna. Fantastic. How are you, Krishna? What are you doing?
Fine, sir. How are you, sir?
Perfect answer. Live to live sperm. Live to live sperms is agglutination. Just remember that. And rest everything is aggregation in other terms. Good. But this is not, we are not doing it anymore. We don't look at.
Thank you so much, sir.
Okay. We're not doing these things anymore, but you have to know 10 people raising their hands. Great. So when sperm sample comes, nowadays we are looking at morphology. Morphology is the most important part. And as all the people who have done hands-on, they know that how important our morphology is. But I'm so great. I was really great getting the answer from Dr. Kavita. Great, madam. And I've really seen people evolving as we are growing. Fantastic. So we are touching number of 301. 301 people have joined us. Great. Thank you very much again. So morphology becomes a very important part of our training. Morphology, we do hands-on, but I'm just giving you some idea that morphology is important. Now coming to our evolution. Now I'm coming to the topic for today and next half an hour. Please be with me because I think we can learn a lot of things from internet, from each other. But let's see how it has evolved. So what happened in 1975, there was a person by the name of Dr. Prasad and Dr. Elvin. So these two somehow got together and they had around 30 other doctors with them. So they had a lot of meetings all over the world. They had meetings in Stockholm, Belgium, Germany. They kept meeting. And they wanted to make some sort of guidelines for semen analysis. That time, semen analysis actually would have been done, but it never existed on WHO panel. So they worked hard. They had multiple meetings. They had, I think, 8 to 10 meetings in those 5 years. 30 doctors led by these guys from WHO. And then they made the first guidelines in WHO by WHO in 1980. This is what you have to know. 1980 May first guidelines came on semen analysis. And it was a small booklet of, it had around 4 or 5 chapters of 8 pages each. A small booklet. And then they thought we'll keep evolving it. So the second one came in 1987. The third one came in 92. Fourth in 1999. And then we have fifth one in 2010 and sixth in 2021. I'm sure looking at the all of you are present here, half of you people, I know more than half of you, we are normally of this vintage. This is our vintage, which we would have seen these bulletins in our life. I started my career with 92. I have got, someone gave me a Xerox copy of 92. I didn't understand much. 1999, by the time I was actively entering into IVF, I could make out something. But 2010 was the one which actually hit us. That was the bulletin, which is a masterpiece. I still say it is a masterpiece. If you don't have, anyway, I'll be giving it to you. We'll give it to you in next 1 hour or so. Then we came WHO 2021. This came this year, and the values are all changing. As you can see here, the volume in 1980 it was not defined. And then the volume has normally been more than 2 ml, 2 ml, 2 ml. It became 1.4 ml in 2010 and 1.5 in 2010 and 1.4 ml in 2021. So in 2021, volume has come down by 0.1 ml. Just remember this. Sperm concentration, which was 200, 20, 20, 20, came down to 15 in 2010, and sperm number has gone up by plus 1%. 16 million is the normospermia now. Then sperm motility, total mortality was 40% initially, and now it has gone up by 2%. It's big change. There are changes which are coming. Initially it was 60%, 50, 50, 50, 40, now it's 42%. Progressive mortality, that's beautiful. Just look at it, gentlemen, ladies. It was nearly 2 in 1980. It became 25. 25A, 25% progressive means active sperms. It became 32 in 2010 and now 30. So the progressive mortality has come down by 2%. Vitality was 58%. Vitality, look at the live sperms. They were 50, 75, 75, 58. It's come to 54% now. So it is minus 4%. In normal morphology, this is one beautiful thing which I want. See, in all our hands-on, the most important thing for a sperm is the morphology. So morphology from 80% in 1980 has come down to 4% now. So this is a brief backgrounder I want to give to you. And now I will go to WHO volumes as they have evolved over a period of nearly 30 years. So first edition came in 1980. Remember, first edition came in 1980, and they started making this edition somewhere in 1975. It took 5 years for them to make a small volume, and now it has been revised multiple number of times, and fifth volume has been the most popular volume of WHO. The largest number of times a document which has been downloaded from the internet from WHO website is the fifth edition. You can imagine how immensely popular that edition is. So now we are coming to sixth edition. Let's see how this performs. This has around 10 years, and the next bulletin is being planned for year 2030, next 10 years. So I'm going to talk to you about the sixth edition today, and I'll take you through this journey. Just close your eyes and look at how the things have progressed. Like we are growing, like we are aging, WHO also is preparing these bulletins for you. First bulletin came in 1980. And just a time, as anyone is of my vintage, you realize that half of our time in the OPDs were carried out in doing sperm cervical mucus interaction. Does anyone remember doing post-coital tests? Any one of you? Has anyone out of you heard about post-coital tests?
Yes, sir. Yes, sir. We have done earlier also.
Yes, sir.
Okay.
Yes, sir.
We have
We
done
used to
earlier
long
also,
back.
sir, post-coital test.
All professors talking.
PCT we used to do in
To see the viability of the
2005.
sperm in the cervical mucus, and especially to see anti-sperm antibody.
Okay, अभी करते हैं क्या? Now are we doing PCT?
No, sir.
Now we don't
2005
do,
we had been
but
doing.
previously we used to do. पहले करते थे, sir.
Even ferning patterns also we
Ferning
used
pattern,
to see. Yes, sir. Of cervical mucus.
I know. I remember that as
Yes,
The
a
thinning of the mucus during a spin bucket phenomenon
yes,
is
yes,
were
yes.
seen during
As
post-coital test.
a PG, we were doing a lot of them in 1995 also.
Yes, sir. Yes, sir.
But now it is no longer. So we'll gradually build up the topic and you'll realize how we are evolving. So please keep contributing. Please keep talking. 1980, this came, and it was focusing on examination of human sperm and cervical mucus interaction. In 1987, it's a green colored bulletin. I'm not able to get it from the internet somehow. It also spoke about the same language, sperm interaction, sperm mucus cervical mucus interaction. Then came in 1992, 1999, 910, 220, 210. What happens in 210? 210, they are gradually moving away from sperm cervical mucus, as you can see here. So they made a very neat manual of examination and processing of human semen. This is 2010. And then This is a new bulletin. This is the 6th edition which we are dealing with now. Let's see how it all started. Gradually, I'll spend only 4 minutes on joining this. And in case I look at our score today, we are 305 people have joined us. So I can't see all of you, but I really appreciate your concern to learn and to evolve. And we are deeply honored at ICET. So first bulletin, 1980. Just remember this, 1980, 43 pages in total. Only 43 pages, gentlemen, ladies. Doctors who made it, there were people who worked so hard that time. So it focused on semen analysis. Take a drop of sperm, see under a microscope, that's what they were doing. Then the main focus somewhere was cervical mucus interaction. They felt that this is going to work for that patient, and they spent a long time working on sperm and cervical mucus interaction. 1980, 43 pages. 1987, next bulletin comes in, 67 pages. It went into 8 languages. Here, they added one more thing. They had standard examination, optional, and then they had cervical mucus interaction, and they also spoke about sperm antibody test. So 1980 came the sperm antibody test. That's the time when we were doing a lot of antigen antibody testings. Does anyone remember doing MAR and those sort of tests? Has anyone done these testings before in their laboratories? Have you heard about them?
Yes, sir.
Immunobeads, direct immunobead and indirect immunobead. We were doing a lot of these tests.
Antibodies at head and
so this was in 19. Yeah. So this is vintage of Maruti 800. Did anyone buy Maruti 800 ever?
Sir, we had earlier Maruti when we started practice. Maruti 800 white color.
Yeah. So 1980 was the Maruti. In case someone had a Maruti that time in that era, they were the big people. Like anyone having a telephone at home that time. In 1980, 82, anyone had a telephone or at a Maruti, they were very big people. They had to be knowing some MP or an MLA. And an HMT watch. That was the era. So 1980 was this era of Maruti, and they spoke about assessment of the semen sample. They spoke about optional examination, zona-free hamster oocyte, antibody test, immature germ cell, cervical mucus interaction, sperm antibody testings. That was an era. And they also spoke and thought about male contraceptives. This was the era of 1980. They thought about this language, and they are the ones who... Can you switch off them, Sandhya, please? So they spoke about the normal semen variables. Volume was more than 2 ml, concentration more than 20 million, sperm count 40 million, mortality 50%, morphology was 50%. This is what I want to tell you. Morphology 50% and vitality 50%. And that's the time they thought about developing something called, they said, okay, let's develop something called time to pregnancy, sort of a thing. And they wanted to see how people can conceive earlier and some conceive late. And they said every lab should develop their own normal range. They thought every country has got their own normal range. They said develop your own normal range, but why some people can conceive earlier, some conceive late. So here, I'm halting here to tell you that that time, the morphology was 50%. 1987 we are on now. And the rest, everything is okay. But the morphology factor was pretty important and the vitality was 50%. And gradually they shifted to the 3rd edition. 3rd edition came in 1992, 107 pages. Here they added, beside the standard proceedings, they also added male infertility regulation, environmental pollution, fertility, controversies in defining the normal range. So 3rd was the most controversial bulletin. And the normal morphology, they made it as more than 30%. There's no data, but somehow this was the most challenged booklet they brought out, and they made it 30%. So WHO 1992 was the controversial bulletin. This you remember. Rest everything is fine, but the morphology more than 30 you have to know, and concentration more than 20%, 20 million, this you have to know. Then as we moved ahead came 4th edition. Now they were getting more defined. As you can look on the screen, they're getting more defined now. They had 3 parts. I always remember them as SOR. 4th edition onwards, they have their 3 terms: SOR, S for standard, O for optional, R for research. Okay, that's the way you won't forget. So the standard they spoke about was semen analysis. Optional, they said add HOS. They added CASA. That's the era when everyone wanted to shift to CASA, and actually it never took off. Then they had free hamster oocyte test, which I've never done, only heard, and they added multiple sperm defects for morphology. So here was the one when we started thinking about the evolution of the sperm WHO manuals, and that was year of, you have to look at the year which came 1999, 128 pages. SOR, standard optional research. And then they also thought about ROS and acrosomal reaction. So that's the time when they were trying to evolve, and that was year 1999. And as we were evolving, you'll find that they made morphology to be around 14%. They did a lot of research and made it 14%. A big change they brought out. Otherwise, all these bulletins still here, they are nearly the same. As you can see, they're nearly the same, barring the morphology. 80, 50, 30, and 14, gentlemen, ladies. Morphology is coming down, and they found that it was enough to give them a pregnancy. They are the normal morphology we're talking about. And as we are moving further, came the 5th edition. This has been my favorite, still my favorite bulletin, which I read every day whenever I get time. I like this bulletin quite a lot. And it came in 210. Look at this, 210, 271 pages. Highest ever download from WHO website is of this 5th edition. You can imagine how beautiful this document is. So please keep it with you, and we'll be giving you both the bulletins in some time. So in these bulletins, they spoke about nearly everything in a more defined way. They added morphology plates, beautiful morphology plates. You can't find such plates anywhere. New procedures for sperm preparation from analysis. They said not only analysis, but sperm preparation techniques they had defined, from testes, epididymis, sperm cryopreservation. So whatever is important. And more than that, they spoke about low volume ejaculate. They spoke about low count ejaculate. Before that, they were actually leaving it. They said sperm not seen, 2 million, 3 million. They were not going further. This volume taught us you have to go into azoospermias and cryptospermias. So this is one beautiful thing about this bulletin of 2010, which had greater detail of the procedures, methods, examples, note, comments, and boxes. And this even the new bulletin of 2020 doesn't have. What 2010 did, it is not done even till now. So it didn't only speak about the total the sperm count, but it spoke about total sperms per ejaculate. They got the concept of total sperm per ejaculate. This was not being done before. Initially, they only spoke about sperm number and volume, but they spoke about total sperm number. So can someone tell me what is the difference between the total motile and total sperm count? Anyone?
Sir, number of sperms in whole volume of
Whole
semen
of the volume.
is total
And then
total sperm
concentration
count,
is per ml.
and per ml is
Concentration, sperm concentration.
Beautiful.
sperm count.
Fantastic. So remember this. What is not important for her, for us, or the her or him, is the 15 million or 14 million sperm count. Because the volume is 3 ml. It'll be 14 into 3. If you look at total sperm count, total motile sperm count. Normally we say count is 5 million. Nothing can happen to this patient. X hi kar do. But that's not the point. In case the volume is 3 million, it will become 15 million.
15 million.
So that's to learn the importance of looking at the total ejaculate. So what they did was something very nice. They had some samples. They took samples from the men who conceived in whose wives conceived between less than 12 months of staying together. They took 400 to 1900 samples from fertile men. 8 countries and 3 continents. 8 countries and 3 continents they took, and they used 5% percentile of the lower reference limit. इससे पहले it was 2.5. They made it 5. They 8 countries, 8 देशों में 3 continent में जाके sample लिए. Between 400 and 1900 samples they took, and then they gave these values, and so it ended here. This is about the 5th edition.